Hello, my name is Luigi Biel, student in Dr. Monica Barman's class for Principles of Public Health, and today I'm here to discuss my analysis on the successful evidence-based intervention for graduated driving licensing programs, or better known as GDL programs. To summarize the program, GDL programs have lowered the incidence rates of motor vehicle injuries amongst drivers since being implemented in 1996 across all of the United States. Through these programs, various laws were enacted which restrict certain privileges for new drivers within targeted age groups that minimize risk and maximizes safety measures to all drivers alike. The target population for this program applies to young adults ages 16 to 18 years of age seeking a driver's license. Program goals is designed to allow new drivers to gain experience by engaging in extended periods of supervised driving time. Through this, it minimizes motor vehicle injury and phases in the new driver with needed driving experience earned at gradually introduced phases. These programs build awareness to safety issues and prohibit a young adult to engage in unsafe driving behaviors. The question being analyzed in this presentation is geared towards state mandate requirements. Every state in the U.S. has implemented a GDL program, though some states are slower than others at updating their laws. Should there be a nationally mandated statute which determines the optimal program measures rather than allow each state to mandate their own GDL program? To better answer this question, one must understand the determinant health factors within the socioeconomic model. Public policy measures enact laws such as mandatory seatbelt usage, nighttime driving restrictions, driver-to-passenger limitations, the restrictions of mobile phone usage while driving, and driving under the influence laws, which will allow new drivers to practice safe driving behaviors. These types of interventions also allow for sustainability and maintenance of healthy driving habits, which ensures the new driver mature into a safe driver in subsequent age groups. By enacting school programs at the community level, such as driver's ed courses, the young adult will be better prepared at identifying and navigating risks associated to driving. State or local organizations can implement initiatives to raise awareness for health hazards which can prevent reckless driving behavior for new drivers. Familial support calls for the involvement and support of strong interpersonal relationships. These individuals, such as parents or older siblings, will assist with closely supervising and monitoring the actions of the new driver for a certain amount of time while the necessary experience is achieved. Lastly, individual new drivers have the social responsibility of respecting the laws set forth by the state to become a licensed driver. By advancing through these phases, it allows the driver to gain the necessary experience needed before going out on the road alone. The target population's diversity is non-contributory as these laws only factor in age of the new driver, ignoring all other demographical data. However, depending on state policies and guidelines, certain states allow for new drivers to advance a phase if certain predefined requisites are met. For example, there were 11 states as of the year 2015 which allow new drivers to have exception to GDL laws. Alabama requirements regarding privately funded driver education within the GDL range is 0 hours compared to the requirements without private driver education, which was set at 30 hours of adult supervised driving time. Other states, such as New Jersey, will allow new teen drivers to be exempt from nighttime driving restrictions for religious or work-related purposes. Public health factors addressed within the GDL program indicate that the interventions have steadily proven fruitful in lowering the motor vehicle injury statistics associated with new drivers. Such examples are indicated by restrictions addressing passenger-to-driver allowances and/or nighttime driving restrictions. Ultimately, changes to existing policies or creation of additional new policies are taking longer to enact, causing additional motor vehicle collisions. Key players identified for the evidence-based intervention include the North Carolina Highway Commission, or NCHC, which conducted 2 studies in the early 1970s which provided insight to what was proposed by Patricia Waller in 1973. Data obtained from the 2 different studies consisted of data linkage of place and time associated to motor vehicle accidents, data linkage of passenger demographic information obtained from accident reports. Patricia F. Waller, who was the first person to suggest GDL programs in the U.S. in 1973, reported to the NCHC that younger drivers faced a higher risk of being involved in motor vehicle injuries due to their lack of experience. The number of nighttime-related vehicular accidents consisting of younger drivers was disproportionately higher than any other age group, and there was a higher incidence rate of motor vehicle accidents when passengers of the same age group were present in the vehicle. The National Highway Traffic Safety Administration, or NHTSA, which quickly enacted laws which mirror the actions that the NCHC performed. Lastly, parents are the most important group within the list, as they are the ones with whom the new driver will be spending a majority of their time obtaining supervised driving hours. Parents are a vital component in providing wisdom and guidance on instilling healthy driving behaviors. External stakeholders involved through the program analysis were driver education communities, which not only provide an opportunity for new drivers to cut their state-mandated supervised driving time, but also assist in instilling competencies required in becoming a better driver. They educate the new driver with knowledge on how to properly use a vehicle, teach them how to skillfully maneuver around obstacles, and most importantly, teach new drivers how to remain composed and not let aggression or aggravation get the best of them. The private sector can consist of automobile manufacturers or insurance companies which approach such GDL programs from an economic financial standpoint. Such opportunities arising from GDL programs can provide an insurance company the ability to lower their level of risk associated to safe new drivers when compared to reckless new drivers, whereas automobile manufacturers can benefit from the advertising opportunity as it can advertise itself as a safe vehicle choice for new drivers, driving the market towards its brand of car. Researchers will typically aim their focus on reducing the amount of accidents there currently are, as they typically assist with the formation of better GDL program policies or program strategies. Highway safety advocates consist of community members who want to spread awareness to certain dangers involved with driving. As an example, you have Mothers Against Driving Drunk, or MAD, which is an organization that spreads DUI awareness and preventive measures to combat it. Medical and health professionals also play a role with being an external stakeholder, as they provide the new driver with patient education, preventive medicine materials that correspond with safe driving practices. For example, don't drink and drive pamphlets, wearing a seatbelt whenever the vehicle is moving, and other related items. Incentives exist for GDL programs through the State Graduated Driver Licensing Incentive Grants Program. Through this program, states can receive grant money if they have GDL laws for drivers younger than 21 years of age, along with compliancy measures and guidelines consisting of a two-stage process applicable to the new drivers prior to given full licensure privileges. Furthermore, communities can offset GDL-related program costs by exploring partnerships with the private sector. One potential ethical concern raised looks at the learner's permit acquisition guidelines. Are new teenage drivers beginning to drive at too early of an age? All 50 states have a different age minimum as to when a new teen driver can potentially obtain a learner's permit. The state of Kansas, for instance, allows for a new driver to obtain their learner's permit at the age of 14 years with parental consent. The state of Kentucky, however, allows for a new driver to get their learner's permit only at age 16. By creating strict standards throughout the country, the number of crashes can further decrease. However, such figures are difficult to quantify, as driving in New York is different to driving in Fargo, North Dakota. A second point deals with GDL program standardization. By standardizing the requirements of GDL laws across the United States, the number of motor vehicle accidents will decrease dramatically, saving plenty of lives. But as mentioned above, what methods can be used to quantify effective legislation? Such standardization may include a minimum age of 16 for a learner's permit, a requirement of 50 to 100 hours of supervised adult driving time before testing for an intermediate license, the minimum age set to 17 years before receiving an intermediate license, and enforced restrictions on nighttime driving. Lastly, no state requires a teenage driver to wait until the age of 18 before receiving an unrestricted driver's license. By implementing such laws as this, states can allow for additional drive times for the new driver along with reduced motor vehicle accidents. Despite there being clear studies indicating that GDL programs are a success towards reducing motor vehicle accidents amongst new teen drivers, there is still opposition on resisting the strengthening of current GDL programs. These GDL opponents assert driver education and training can provide the same statistic associated to crash reduction and fatality linked to GDL programs. However, no recent study has shown that teenage driver education effectively reduces either the rate or the severity of young driver crash involvement. Regardless of what critics believe, data shows differently as there were no state-mandated GDL programs prior to 1996 to phase in new drivers. This data shows teen-linked motor vehicle crash rates to be at their highest amongst the target population, which was 40%. For new drivers ages 16 to 17 years, a change which was desperately needed. Reduction in these crash rates occurred after North Carolina introduced its first GDL program. Several states followed suit and crash rates began to decrease. As of 2012, the percentage change of motor vehicle crashes amongst new drivers ages 16 to 17 have changed by nearly 80%. Additional changes via strengthening of current GDL programs or providing improvements to already established laws can increase rates of adherence in motor vehicle collision prevention. How can we spread the word? For licensing policies, state-by-state comparisons can be used to indicate which laws rank highest throughout a rating system. Modifications to pre-existing policies which rank poorly can then be reevaluated to identify proper governance for new teen drivers within GDL programs. Adoptions of these modified policies via additional programs which can provide economic stimulus to state or individual insurance policyholders along with strong law enforcement policing can lead to substantial reductions in motor vehicle crashes. Secondly, health communication initiatives through social marketing campaigns can be used to raise awareness and increase prevention against risky health behaviors that are associated to teenage driving. Campaigns which use persuasive, emotional messages to spread awareness are most effective when aimed towards young drivers. Initiatives which emphasize awareness along with listed ramifications to impaired driving, cell phone use, seatbelt use, and passenger restrictions can be used to deliver adherence to both new and older drivers alike. Lastly, the involvement of parents of young teenage drivers plays a key role in obtaining adherence to GDL program measures. Parental influence on driving restrictions associated to teen drivers can lead to less risky driving behaviors. Furthermore, by instilling mandated or incentivized parent-adolescent driver contract subprograms, this can provide additional support in enhancing GDL program compliancy. In conclusion, since the inception of the GDL program in 1996, implementation throughout the entire country has been successful in effectively reducing the number of motor vehicle collisions amongst new drivers while providing needed driving experience for new teenage drivers between the ages of 15 and 18 years of age. It has granted them with the opportunity to safely yet effectively learn driving behaviors via different levels to take on the growing complexities associated with driving. Through these levels, confidence is attained to raise self-efficacy of the new driver along with gaining invaluable experience. Short and long-term effects can easily be associated with one another as short-term effects easily feed into long-term effects. Adherence to safety measures are formed at an early age, and by mandating the sense of safety at point of instruction, new drivers will be able to practice safe driving skills past the GDL program range. Furthermore, by enacting nationally mandated measures to one unified GDL program, further reductions in motor vehicle conditions incidences will occur, allowing for additional long-term benefits. Thank you for listening to my presentation. Below is the list of provided references. Have a wonderful day.